Welcome to part 2 of the Delirium Diagnosis and Management Workshop. In part 1, we considered the problem of delirium and why it's so important. Now, in part 2, we move on to consider what is delirium, how is it defined, and how can it best be diagnosed both in clinical and research practice. With this in mind, it's useful to consider how medical science has considered the problem of acute generalized disturbances of brain function through the ages. The first documented descriptions of delirium probably date back to Hippocrates' aphorisms. The Greek physician was well attuned to the notion that brain disturbances could be caused by physical illness. And although he didn't specifically use the term delirium, his descriptions of phrenitis and lethargus closely correspond with what we today call hyperactive and hypoactive delirium respectively. However, it wasn't until 1 AD that the Roman scholar Celsus used the word delirium to describe acute brain failure in the context of physical illness. Thereafter, the concept of delirium has been dominated by the description of clouding of consciousness. This was first described in the 19th century by the German physician Greiner. Clouding of consciousness captures the disconnect that occurs when a clinician tries to communicate with a patient with delirium. But it's a rather elusive concept that's hard to define and is not readily applicable to routine systematic assessment. Clouding of consciousness cannot be reliably operationalized into testable cognitive domains, and as such is not especially useful for the clinician trying to detect delirium in everyday clinical practice. Indeed, an over-reliance on ill-defined concepts such as confusion and clouding of consciousness has contributed substantially to the historical poor detection of delirium in clinical practice. As an illustration, why not take 30 seconds to consider what's your best description of confusion and of clouding of consciousness as concepts? The arrival of DSM III in 1980 brought much better clarity to our descriptions of acute generalized disturbances of brain function. Delirium emerged as the dominant nosological term to describe all acute organic disturbances of brain function, and its diagnosis is based essentially on 4 features that are based upon the context and character of neurocognitive disturbances. This enhanced diagnostic clarity has allowed for more coherent research effort along with more consistent clinical practice. It is important to note that as an umbrella term, delirium has subsumed a whole host of previously used labels. Amongst the more common are terms such as acute confusional state, ICU psychosis, acute brain failure, toxic encephalopathy, and postoperative psychosis, and even includes unusual terms such as subacute befuddlement. As this slide depicts, the concept of delirium is very broad indeed and includes all acute and subacute generalized disturbances of brain function. In an effort to better understand what delirium is, it's useful to revisit its overall phenomenological profile. Delirium is described as a complex neuropsychiatric syndrome, and in essence this means that it includes a wide range of neurocognitive and neuropsychiatric disturbances. However, no single symptom is specific to delirium, and it lacks a pathognomic feature. Despite this, the character of some disturbances, such as the intensity of sleep-wake cycle disturbances, their context, where there is acute physical illness, and their course, which typically involves acute or subacute onset and fluctuation, is highly indicative of delirium. In fact, one might ask, what else causes that clinical picture? DSM IV remains the most commonly used diagnostic system for delirium. In essence, it consists of 4 key features. These are altered consciousness with a disproportionate disturbance of attention, evidence of generalized disturbance of brain function, a relatively acute onset, often with symptom fluctuation, and also that symptoms should occur in the context of physical illness. An important implication of these criteria is that the accurate assessment of cognition is the cornerstone of reliable identification of delirium. Why not reflect upon these criteria for a moment and consider this conundrum? If you were asked to conduct a point prevalence study of the frequency of delirium in the medico-surgical wards of a 200-bedded regional hospital, how would you optimally and efficiently identify the presence of delirium? As a hint, you might want to consider a means by which you can outrule cases of non-delirium first. Welcome back. We hope you had fun with that exercise. This is a problem that's been considered by a number of research teams, and essentially they have come up with a solution that involves a 2-stepped approach to diagnosis and identification of delirium. The first step involves screening all patients at risk of delirium for delirium-relevant disturbances. This requires a test that is highly sensitive to the presence of delirium that can be applied like a cognitive vital sign. The second step involves an assessment which is more specific for the presence of delirium and is usually applied to all patients who screen positive for step 1. In our efforts to find a vital sign for the brain, it's useful to revisit the diagnostic criteria for delirium, which very much emphasize a disproportionate disturbance of attention as a required or mandatory feature. Disturbed attention is considered the cardinal cognitive deficit of delirium, and indeed is required for a diagnosis to be made. This is based upon a series of studies which have demonstrated the importance of impairments of attention in delirium. This slide shows a series of radar graphs. Essentially, the 13 arms on the radar project from a central point, and each reflects a symptom of delirium. The further along the arm, the more affected that symptom domain is. They therefore provide a visual representation, or if you like, a footprint of the phenomenological profile of delirium. These studies have shown that attention is disproportionately affected in patients with delirium, that this impairment occurs over the course of the episode of delirium and across different populations who experience delirium. Also of note, disturbances of attention are highly correlated with disturbances in other cognitive domains that are relevant to delirium. As such, disturbances of attention are considered to be a good marker of possible delirium. It's also worth noting that a series of studies have also shown that simple tests of attention can identify the disturbed attention of delirium and distinguish it from its key differentials, depression and dementia. This slide shows 3 such studies. A key finding is that performance on simple tests of attention and vigilance are relatively preserved in patients with depression and dementia compared to those with delirium. In short, accurate assessment of attention is key to diagnosis of delirium. Why not take some time out to consider how do you assess cognition in your routine everyday practice, and specifically, how do you assess attention? Given that testing attention is so important in clinical practice, it's perhaps not surprising that there are a whole range of different tests available that you might choose. These include reciting the word world backwards, subtracting 7 serially from 100, reciting the months of the year backwards or the days of the week in reverse, the digit and the spatial span tests, and vigilance A test. But in fact, many clinicians actually rely on their subjective assessment of attention based on a brief conversation with the patient. But you might ask, is there evidence to point us towards which is the best test to use in clinical practice? First up, we should consider what are the characteristics of a good test. In everyday clinical practice, a good bedside test should not only be accurate for the target deficit, but also should be simple, brief, easy to use at the bedside, should require limited skills to administer, and should be easy to interpret. It's worth noting that although clinicians readily recognize these tests, when they're asked specifically what corresponds with a pass or a fail on the test, they're much less certain. Also, when clinicians are asked how they administer these tests, we find that there's considerable heterogeneity in how they're delivered in everyday clinical practice. These inconsistencies only add to the difficulties in reliable diagnosis of delirium. Head-to-head tests that compare the utility of the different tests of attention in the diagnosis of delirium are relatively rare. One revealing study by O'Regan and colleagues compared the use of the months backwards test with other approaches to assessing attention in general hospital patients, and found that for the detection of delirium, the months backwards test was better than the other approaches, that this applied across different age groups, including the very old and including those with comorbid dementia. Similarly, other studies by Adamus et al. And Leonard and colleagues have also found that the months backwards test may have advantages over other tests of attention in terms of its accuracy for detection of delirium in real-world settings. With this in mind, a recent review published in the World Journal of Psychiatry by James Marr and colleagues, considering the use of the months backwards test in clinical populations, is particularly illuminating. They reviewed over 40 different studies, and in this found that there were more than a dozen variants of the months backwards test reported, both in terms of its administration and interpretation. Helpfully, the review concludes by making suggestions as to how the months backwards test can be optimally used both in clinical and research studies. They recommend that in subjects who are over age 65, that they should be able to recite the months of the year all the way back to January without error in order to pass the test. In subjects who are over age 65, they should be able to recite the months of the year all the way back to at least July with a maximum of 1 error. They considered errors to be those of omission rather than commission. It is hoped with these guidelines that this can allow for more consistent use of this important test in both clinical and research practice. The next issue to consider is, once we have identified possible delirium, for example by virtue of the presence of significant inattention, what is the best means of clarifying an actual diagnosis of delirium? At this point, things become considerably more challenging. For clinical practice, we typically rely upon informal application of DSM criteria. However, given the poor identification of delirium in real-world practice, where typically 50% of cases are missed or misdiagnosed, this can hardly be considered an especially effective approach to diagnosis. For research, the best standard is to apply DSM IV criteria based upon a full neuropsychiatric assessment. Unfortunately, the expert skills required for full neuropsychiatric assessment are not always readily available, and as such, many clinicians and researchers tend to use diagnostic tools in an effort to improve their detection of delirium. Tools such as the CAM ICU, the NuDesk and the DOS can all assist with screening efforts, but these are all imperfect and tend to lack sensitivity when used by non-experts. At the other end of the scale, specialist diagnostic tools such as the revised delirium rating scale and the cognitive test for delirium require that the assessor have specific skills and training, which significantly limits their use beyond research and in challenging diagnostic cases. As such, it is behoving upon clinicians to identify ways they can apply DSM criteria in more systematic and reliable ways. In choosing the most suitable approach, one needs to consider both its purpose and the resources available to assist with diagnosis. Key questions include: how much time is available for diagnostic effort? What is the background and skill set of the assessor? What is the patient population in which the assessment is occurring? And in particular, what are the likely rates of dementia? What's the level of training that's available for assessors? And what's the purpose of the diagnosis? Is it a clinical diagnosis or is it for research purposes? It's worth bearing in mind that the CAM remains the most widely used diagnostic tool in research studies globally. The CAM is a 4-item tool based on DSM III criteria, and it has some significant advantages in terms of its simplicity and brevity. However, amongst its issues, the CAM tends to lack sensitivity when used by non-experts and also includes assessment for disorganized thinking. Take some time out to view this video of the CAM being applied in actual clinical practice. So in summary, we suggest the following approach to practical delirium diagnosis. First of all, screen for impaired attention using a reliable and readily interpretable test such as the Month's Backwards test. In those who screen positive, one should look for other DSM criteria. Careful discussion with nurses and a collateral history can clarify the acuity of onset and whether there is fluctuation of symptom severity over time. Careful review can also uncover the presence of delirium-relevant physical etiologies and should include a careful review of medications. The presence of more generalized disturbances of cognition can be established through testing for orientation and visuospatial function, as well as assessing for other neuropsychiatric disturbances such as those to thinking, perception, sleep-wake cycle and motor activity. In cases where there is remaining diagnostic uncertainty, one can use other tools such as the delirium rating scale, the revised delirium rating scale, the cognitive test for delirium, or indeed seek an expert opinion. Finally, it's important to remember that delirium takes precedence over all other diagnoses by virtue of its acuity, its link to serious physical illness, and also its association with a range of adverse and undesirable health outcomes. Thank you for listening to part 2 of our Delirium Diagnosis and Management workshop. In part 3, we will move on to consider some clinical scenarios where the diagnosis of delirium is particularly problematic.